the outset, I would like to thank the organizers. It's always nice to get back to your college. And it's even better when you have your own teachers amidst the crowd. I saw my UG teacher, Rajlu sir, and my PG teacher, Colonel Apte is here, and my FEMA guru, Dr. Supe is here. So thank you so much. And I would like to thank Day and Colonel Makhani to carry on the good work. So this journey of simulation started while I was the NMC convener, and we had taken students in September 22 to MUHS, where we have another stalwart in medical education who had thought about it. And look at how the students are actually interacting with this model. And this is a HoloLens which they are wearing, and it's an anatomy model which was initially built. And this happened just after I had done my advanced course in digital health and imaging. And somehow I could see them getting together. And in fact, just to answer one question which Dr. Praveen had, that little doubt as an educationist of subjectivity, maybe we can have some neural networks which will help us later. So that's where, these things could bridge the education and we call it machine learning and artificial learning, but everything can be just bridged together. So that's where I got excited about it, and I came back to the Miller's pyramid, which we always keep on talking about. And as you see, it shows how and does we do have a computer simulation somewhere there, but it's still not seeing the light of the day. And as an educationist, I would want this computer simulation to go here, where I can at least see him do it, maybe not perform. Perform will be obviously in a off-site or on-site simulation. So with this little, I would say, a requirement as an educator, let's go ahead to our skills training workshop booklet, UG booklet. So you remember you taught me so much while we were compiling this booklet. So this is the feasibility criticality matrix, which we always talk about when we are making a skills training session. So on the x-axis is the relevance, and on the y-axis is the feasibility. Now, the problem lies when the feasibility is low and the criticality is high. So the relevance is high, but the feasibility is low. Now, this is the place where skills lab and simulation play an immense role, where you can teach the student before he goes actually into the real world. And this is where, as an educator, we have to play a role, define our objectives clearly, have a teaching learning method, same old principles of education, have our assessment in place, and only then we can have a good student who will be actually trained in a particular thing. Now, also the confusion here of how to go about it. To bring it down simply, we cannot avoid it. This is a eye gym which has been created for patients by doctors. So if my patient requires this, these are autistic children, specially able children, where the entire floor has been made, which is very interactive. And a simple principle which is used is that there is a personal space which is given to the individual. The individual is on a wheelchair or is not able-bodied. And when he's sitting in his little external thing, in that external space, if he wants to interact with the environment, all he needs to do is either press a button, or if it might be put on a knee or a hand, depending on the ability he has. And as a child, he could kick the ball. So if those of you who are interested, youngsters, you can see this video of iGym, where the mother actually was in tears, said, I had never seen my child play with my elder sibling who could actually, not play. So if the doctors are required to do this in the future, gentlemen, ladies and gentlemen, I don't think we as educators can be sitting behind and thinking of how this doctor is going to do it without getting educated in the curriculum. So another thing which we have just seen is Sarah. Sarah is, for those of you who are interested, this is Sarah, and you can actually talk to Sarah. I'm sorry, I think, yeah, that's it. So Sarah is a health assistant, a virtual health assistant, which has come up with the WHO, and you can talk to Sarah. Sarah can talk about so many things. But of late, while I was Googling Sarah, I came to know that there are some mistakes which Sarah is making these days. And who is responsible? I think the lack of training on our part, where we are not able to change the system and we are not able to update the system, whereas we want the system to work for us. So this was just a realization that there is a felt need for this. How do I, the keypad is not functioning. It's not moving. Can I just do this? Oh, okay. It's a headphone. So let us know. Let it be. I think we'll go to the next one. Start. Oh, it's saying starting. Okay, let me go back to the other videos then. So maybe we'll go ahead. So what I wanted to bring in here was that it is inevitable, as rightly the title goes, that the educators cannot be sitting behind, and whereas we want the doctors to be actually leading on the AI front. So if the criticality soon creeps in, yeah. So if the criticality creeps in, there is a necessity, which is for medicine, as we know, that we want to make our performer to go to the performs, and it has to be taught. So then let's understand, as an educator, this talk is going to be very, very basic, because we have a stalwart after me who's going to do the simulations using haptics. But I'm going to just take you through this journey of basics so that you don't get scared. And actually, this is my journey of these 2-3 years, because now, when you realize there's an importance, you start reading about it. So let's go ahead. So this is a reality, virtuality kind of a spectrum. And to understand AR and VR, all we need to know is where we want our education model to be. So a real environment on one side and an absolute virtual environment on the other side. In the real environment, if we augment it, it's augmented reality. If there is a virtual environment, it is a virtual reality. And if there's more of virtuality, this is a terminology which is not used much, but this can be used later, where there's more of virtuality and less of real, it becomes an augmented virtuality. Now, if we want to compare the two, what is VR and what is AR? These were my doubts initially, so I'm sure some of you will benefit, and that's why these quick slides. So virtual reality, the reality is synthetic, and augmented reality is actually real world. The importance lies here that the virtual reality is computer generated. There is no real world. So you need to have your device, you need to have your software ready to make sure that the reality, the virtual reality which is created, is as good as real. And that is where the devices and the technique and the softwares play an important role. And that is where we should understand what we want. Augmented reality is where the individual sees both real and virtual, and it's called as a composite view because you're superimposing on one another. Virtual reality has a lot of autonomy. User has controls. AR is interactive. Head and eye tracking is very important. So sensors, the development of sensors and their technology has played an immense role in getting these models ready, because your hand tracking, eye tracking should be captured immediately, put into the algorithm, so that the entire real world, or the real world which we have put into the system, should change according to how we are moving. And AR is registered in 3D, so then it is aligned into the real and the virtual objects in physical world. As an educator, what do I want? I want whether my design should be single user, multiple user, or a social user. Social user is more of society use. You're walking around with your Google glasses, and you can see these days Google has come up with these Google glasses, and you see these ads which keep on popping up. So you see that so-and-so profile, what is happening around, where is the nearest map to something. That is a social user. You might need it for something, but I think today's relevance, do you want a single user or a multiple user interacting? So do you want the teacher also there? Do you want two students doing it? Do you want a team mechanics? that will decide your people. Whether it's an able-bodied or any user, again, whether it's somebody you need to add some more sensors to, or you want somebody to be interacting in a different kind of a space, you have to be ready in that model. What are the tasks? Can I do it only with the tabletop? Something what ENT is already doing. You have a tabletop. I think it's a computer model where you can actually feel the haptics. We have recently got in RR also. We have an endo trainer with haptics. You can do it on a tabletop. Or do you want it standing in a room? So in a room, do you want it with augmented with reality, or do you only want virtuality with yourself with the hand tracking? On the go or in the world. So you can be actually practicing a critical thing actually in a real world with your gadgets on, and that can be assessed. So again, educator will decide this. Where do I want to actually assess? So something very critical in forces, maybe we want it on the go in a simulated environment. Technology driven, and that is one of the reasons why it is very exorbitant. And as it was brought out in the morning, I agree that unless we learn, we will always be afraid of this technology. We will always not know what to do and how to use these things, and we'll get cajoled by the terminologies which are thrown at us and get scared. So you can have specific platforms, or you can have cross platforms. Cross platforms, again, do you want to merge 2-3 scenarios together? Do you want two realities, augmented and virtual, together? Do you want augmentation happening on an actual mannequin or a 3D model? All that depends on what your software is. And what are the devices? So devices started with very tethered devices. A simple Google Cardboard was first of its kind. Then it went to standalone, where we had some which we could add on, like a Oculus. You could add on and make it into a built-in almost. And now we have HoloLens, which is a built-in, totally very sophisticated thing where you don't require anything else, and you can see the environment. Again, the displays also can be two types. It can be a see-through display, or it can be a monitor or a computer-based display. So this we have to be very clear about. Then you decide for your objectives. What aspects of reality you want to touch? So I heard the lady talk about the haptics, that she wanted the student to learn the actual feel of the tissue. So that is where it is very important for her. Whereas for somebody else, it may be the audio file. It may be the taste of flavor. It may be the smell. It may be the identification of motion. Depending on what your objective is, you need to have your sensors in place and the software. What number of environments are you dealing with? Is it physical or virtual? Because if you have a kind of an AR and a VR setting both, it is two environments, because the VR environment is different from the AR environment. So you are actually making a complex scenario. So simple, what number of environments do you want? Number of users, as I already said. What is the level of immersion we want? How much should the person feel like he is actually doing it? What is the level of virtuality, and what is the degree of interaction? All these to keep in mind, simple objectives. So now a word about what will be augmented reality. Augmented reality, always, you get it very simple. It is divided into 3 parts. What is the extent of the world knowledge you want in? Is it a modeled world or an unmodeled world? Where do you want it to happen? What is the reproduction fidelity? So we're going to talk about reproduction fidelity again. But let me just complete. What is the extent of presence you want of the person who's playing it? Do you want it feeling him doing it? Or do you want him seeing it and then coming there? So it's an egocentric or an exocentric presence. So again, entire model will change. And the reproduction fidelity, the extent of world knowledge, and the EPM can all be put up into your paradigm, where you can, again, like we did the feasibility criticality matrix. Similarly, on this, you can plot how much you want what, and then you have to just tell your engineer, I want this. They'll give you the options depending on your money, your budget. You can pick up the right option, find which is the technology which matches with it, get the software, and 2 types of software is what you will require. One software for the user and one software for the developer side. And both should be in harmony. The problem is that most of them are driven by, technology bosses, I would say, because the softwares have been made that they're compatible with each other. But if you understand these little basics, then you can go for the lower models. You can even think and innovate in your own self how you can do it. Like in a teaching session, if you have a mannequin, you can always have an OSCE with a small virtual environment where actually there's a mannequin on the second table where he actually performs the particular task. You can assess the mannequin, but the actual environment is just giving him an insight, and he can probably be just telling you the history that he got. So actual patient interaction, which you needed a standardized patient, you may not require because that standardized patient is already there. I mean, we'll have to think like this, innovate like this, and we can start with OSCEs in such a way. So this is the reproduction fidelity. So if you see on one side, it's a monoscopic video, and on the other side, it's an absolute 3D visual display of what you want. And this is from a very old article, which still holds true, of Milgram et al. In 1994. If you're interested, you can read this article. It's a real insight into the basic technology. So monoscopic video, simple wireframe is required. So you have to just tell your engineer, I don't want anything fancy because I'm only looking at monoscopic video. If you want a color video, a visible surface imaging, that can be shaded, textured, consistency can be given to make it more real, and depending on how much money you have. You can also have ray tracing, that how the tracing is happening, which becomes a more high definition video. And finally, it can be a high fidelity, 3D animation, total photorealism, hyperrealism space, depending on the budget and the requirement. So this adds to your third limb of the paradigm. So depicting AR and VR in hyperspace, we require reality. And of course, you want reality to make him have an immersive experience. And that is where immersion will play a role, because how much real can you make it? You can't expect a virtual, probably a computer generated, to make it very real. But if you want him to certify in something, or you want him to, something which is very critical, especially for the armed forces, like disaster drills or something like that, which you want to do virtual, it has to be totally as good as real. But if you want him to, before go for disaster drill, at least learn something, a small little model will be good enough. And last is the directness of whether primary world objects are viewed directly or by means of some electronic synthesis process. Now, the changes reduce the complexity. And as I said, from tethered to standalone to built-in, we had various things. How many of us have been using an AR app? Actually, all of you are. And if you just go to your google.com and type any animal, tiger. So there'll be a drop-down menu which will say tiger in 3D. Click tiger in 3D. And you will get a tiger in 3D available to you. And when you put your device to the place where you want to see, that tiger will be sitting there. And how has it happened? Simple depth perception camera. I've just done it. This is at airport. Depth perception camera, software based, using depth perception. Sorry, I think it just moved. Very simple. So technology is already there with us. It's just how we use it. And this is just a depth perception camera that you have with the software, which is already there in your mobile, which is taking that 3D and placing it into the space which you are giving it. So you can use this thing. And now imagine if you have a 3D model of something which you want to place, you can do it. It's just a smartphone. The student doesn't have to have any fancy thing. It's just a smartphone that the person requires. So this is one, I have this thing about the companies which will keep on coming up. These are just examples which will crop up. There are many more companies available, but I just thought a kind of a scenario might be, give you more insight. So this is one of the virtual reality clinics which has been created by a clinician. So does this company say. And this is where you can interact, you can do various setting changes, you can do, changes of medicines and various things you can plan. And as an educator, while I was seeing this video, it really requires a clinician to think about where and how I'm going to place my objects. And that is where the role of training a doctor comes in. I feel if we are trained, we may not spend crores on this, but we can at least make some model which will be relevant to us, because of that small objective which we want to reach, which may not be very fancy of a clinic, but at least a small little thing. I'm also going to show you some examples just for educational purposes. And one of them, which I found really interesting, is a virtual training model of operational medical training, which is actually being done by US Air Force.
Military personnel need to be prepared to treat and stabilize a wide range of injuries across the continuum of care. But current training methods required to maintain medical readiness are expensive, time-consuming, and limited. To meet these challenges, CMEX has developed the Valor program. This virtual reality medical simulation system is designed to practice clinical and operational decision-making in a fully immersive environment, while also saving time, money, and resources. Created with over $10 million in U.S. Air Force research and development funding, CMEX is already in operational use at over 20 installations within the U.S. Air Force and Defense Health Agency. Virtual reality training offers huge advantages over traditional simulation mannequins, which are expensive, cumbersome, and very limited in what they can portray. With VR, the patient can be a warfighter with a traumatic brain injury on the battlefield, a local national with multiple traumatic injuries on a medevac flight, or a contractor suffering the effects of high altitude.
It's getting real hard to breathe.
Simulate the wide variety of training environments from the side of the road after an IED explosion to the inside of a CV-22.
So it has many such things in it. And what level of domain is it for educators here? Miller's pyramid of competence. Anybody? It's not does. It's actually just clicking that device. It's not putting it itself. So it's still at a knows how level. Sir, am I right? It's not actually doing the skill. So when he had to put the tourniquet, he just touched the tourniquet, and tourniquet just went to that site and got itself done. So if you remember, as an educator, this is still at a knows how level, but it's an important tool because maybe Air Force thought that this kind of a training is required before they actually face a situation like this. And it's a brilliantly made model, but it's still not reaching does. Right. Let me go back. I'm not going to show you a virtual patient because sir is going to have lots of them. Let me just take you to another one of this.
This has been the most eye-opening and intriguing learning experience in my life so far.
Altera is going to be the highest.
Also has sounds because we felt sounds are important in this. Again, if you notice, it's actually a skill. It's just picking up objects and putting it in 3D. And this is where it differs, where you have a team management now, where other avatars have come in and they're going to compress, they are going to do, do a task together. So just wanted to highlight that how it has grown. So you have one person doing the CPR, the other person, and it's like a team that you have made, which is very good for inter-professional team building, which we often talk about in education. So this is another example. And let me just take you to one virtual clinic now. Where the text messages are coming when you do a particular task. That's like learning method. Various choices. And so on like that. I just wanted to give you a glimpse. So what it helps us understand is that sky is the limit as an educator. But what is most important is something called as a game product design. Whenever you want to come out with VR or AR, you have to have a game product design. It's not a game, it's a design which you want of what characters should play in it, what all will happen, what do I want the learning to be, where a text should message, when should he get points, when is the time when he should be told that this is wrong. That is an entire design framework that one has to make. And that is the role of an educator. I think if we are able to make that game product design well, because we understand what we want in the available technology, we have engineers to back up to make the right product for us. So with this, the last part of it is, of course, the most important too, and hence, what are the risks for VR and AR? One of the very, very reported risks, especially of VR, is the motion sickness, because you're in a virtual 3D world, which is actually not perceived by your foot. So there's a kind of a dilemma to the brain. And this, especially if you're having a learning training moment, which is of a longer duration, it can cause little problem to the person who's doing it. The second for both is information overload, because so much of information is going to the student at one time. So maybe you have to decide how you're going to build that or how many versions you're going to have so that he reaches, does, or shows how. The intensification of experience is another thing where the person is actually coping with that disaster live. Although it's in virtual reality, but he's going to have an emotional stress to it. He has to respond to it, and that should be kept in mind as an educator. And last is, of course, which is most important, the experiences that he's having cognitively, emotionally, and behaviorally, he should be able to disengage from it when he's reaching VR, when he's coming out of the VR. Or when he's entering the VR, he should realize that he has to be detached. And that would also require some kind of a training to our learner. Now, the issues at hand currently are the devices and the technology which don't talk to each other. They are still in silos, most of them. And the social issues, which is privacy, security, and ethical issues. One of the very important papers, which I would like to quote here, is by Slater, 2020, the ethical issues of this realism dilemma. Those of you who should read it, who are thinking of being an educator using AI, because this is where you will, right from the beginning, you will understand what all can while you're making a scenario. And hope you begin your journey to the inevitable. Thank you so much.
Thank you, ma'am, for that very invigorating and engrossing talk. In fact, you have always charted the uncharted. In fact, and more so, you have today encouraged us all to, in fact, break our mental shackles and embrace this new technology. For that, it would definitely empower us all to train the INGs to what they are, or in fact, from what they are supposed to be doing. In fact, to be the world leaders in medical giving healthcare. I would now invite two questions from the audience, in case if there are any. So please.
Yeah, thank you, ma'am. My name is Dr. Amit Agarwal. I'm a professor in medicine at Symbiosis Medical College. I really appreciate the way you have concised the talk into the usable intelligence into our day-to-day teaching that we do for our undergraduates and postgraduate students. But I just want to share here my experience with the virtual reality thing, where one of the companies they came and they were, promoting, let us say, and they just gave us we have to wear that headgear, and then we have to, see, like, let us say a simple example, how to put in an IV cannula, or let us say take an ABG sample. But what I could understand wearing this gadget was that it is a very, tough thing to maneuver, and at the same time, the real situation where you learn how to put an IV cannula has so many things which you actually teach. When I was taught by my, senior, how to put an IV cannula, there were so many things which I understood at that time, which are still fresh in my memory. But when it comes to a virtual domain, I saw that they were it became very, artificial in a way, and there were so many things which were missing, which can only be understood in a real life situation when you actually take an ABG sample or an IV cannulation. So my understanding here at this point is that it will be very limiting. I don't know, in due course of time, it might improve the way intelligence is growing, as people are talking about haptics and the touch feel and all those things will come. But as of now, my understanding is that it will be very, limiting in a way to actually impart that learning to an individual who is learning, let us say, a basic skill of cannulation or taking an ABG sample, or let us say doing a percussion, or because it looks very fancy when we see the picture, but wearing a headgear and then doing so many things, it actually is much simpler when you have a resident standing besides you and you're giving him the information right in a real world situation. So any comment on that?
So I think what you've said is the highlight of this article, because I fully agree with you that when you see something which is brought to you, you find some nuances which probably could have been bettered. Now, my take on this would be that technology is in, and sensors, with the development of sensors, with the development of the software which we can, access to, the amount of data storage, the cloud storage that we have, it's easy to do. So I think the only thing which is missing is that the design which was made was not by the doctor. So you are ready to start writing your game product designs. I think that is where we are lacking right now, that we are hesitant in starting it, and we are depending totally on technology driven people, where obviously I don't blame them. They also don't have that insight. But if a doctor is writing that game product design after talking to the clinicians, after talking to the doctors, what exactly do you want in this skill training session? And if we write that design, I'm sure it's going to see the light of the day, at least hope for it. But I think you have just summarized what I wanted to say, and that's why I went so simple. Thank you so much.
Colonel Karuna, may I?
Sir?
Excellent talk as usual.
Sir, thank you.
Excellent talk. Now, I just wanted to ask you, AR, VR, cost of a goggle.
So HoloLens is around, in fact, I was very interested to buy it myself. So for myself, then I thought my husband is going to be after me. So it's almost around 1.75, 1.8
So for a
lakhs.
medical college with 150, 200 students, how many do you recommend?
Now, it again depends on the model, sir. If it's just single user, one HoloLens is okay.
For
But
200 students?
But why go for a HoloLens, I'm saying? At least before we go to the HoloLens, start learning how to make those models using the HoloLens. The problem is HoloLens comes and we don't know what to do with it. In fact, that way MUHS was very smart. I mean, they have really had this hub and spoke model where people have made models with the HoloLens. So many is getting added on, and actual realistic thing has started to happen.
Yeah, because RGHS, Vaidehi has come up with this
Very nice.
new pattern. But the cost is the embargo here, as you said. So the cheaper, sir, please, that'll be great. I think the students, it may make sense to be, moving fast into it.
Sir.
By the time we make it, may take another 3 years, 4 years.
Sir. And in the interim, maybe we can train our educators so that they can be ready to be compliant with it. Thank you, sir.
Please, sir.
Am I disqualified from asking a question?
Not at all, sir. Please, sir.
Okay. So, no, I must compliment for a wonderful talk, but that's the homework. But more importantly, I think there is a very valid point which has been brought out by him. Actually, we are trying to look at this technology and trying to think it will solve everything. So I think everything has a place. And when it comes to complex scenarios or complex, like that matrix was shown, for example, in the armed forces, specifically, or if you're looking at a very rare situation to be practiced and done 3D realism, putting an IV cannula is not what these tools are for. These tools are, suppose if you want to practice 6 people trying to evacuate a patient from maybe an accident site to an ambulance. So these are what these skills are for. And I think we have to take it in that context where you can't really practice these things day to day. You have to fill a gap. Putting an IV is not the gap. So the gap here is actually looking at these complex scenarios, like in the army, if you want to say, I want to practice in an urban warfare, and I want to fire, and I want to move around in a room, and I want to use sort of augmented reality. So that's where the gap we need to identify, and that's where it's so important that the doctors drive technology rather than technology driving the doctors. So that is very important.
Thank you.
And that would be last question, please. Yeah.
I'm Tarun, and I have my own startup in AI in IIT Delhi. So one of the questions, and I always debate with my fellow people at VR, is how close are these models with the real world situation? For example, at many, so I come from a family full of doctors. My parents are from AIIMS, New Delhi. At all these institutions, they tell you to write how to write a prescription. I'm just giving an example. It has to be capital letter, it has to be generic, many other things. When I went to these hospitals myself, in general medicine, you have 500 patients, 3 or 4 doctors. And what they do with prescription is everyone knows. So what I'm trying to tell is, for example, cricket example, you practice, but real world situation when there are 1 lakh people watching, what goes in the batsman's mind is very different than what you do in VR, actually. So how do you think, ma'am, that these models can come close to the reality so that doctors are actually adapted to the real world, how it's going to be because of the patient load or other situations? Thank you so much.
Thank you for the comment. Actually, I would just like to say that this is for us to decide as to where we really need to have an interface. And if we need to have an interface, we can't live in silos. I can, I would like to say for myself that if I want something to be done, I can't be in my own silo as a doctor, because as a team who's developing it for me, like maybe, as a startup, when you want to understand, you would like to understand what exactly I want it for. And if I'm not clear about it as to what all features I want in it, what exactly should be there, how often it should be done, how much should be the time that it should take to assess or maybe to load that information, I can only talk about the doctor's side, then we are a failure if we want to adopt a technology without understanding that technology. That's all I would like to say. You are the stalwarts, you can actually make it, but it will fail if we have not asked for what we want. And that's where that game product design is very important. And we should understand what exactly do we want. That's all. And maybe time has come slowly. I heard some courses have started. One is also there in MUHS. Slowly, this training will happen where undergraduates and postgraduates will be ready to actually demand or ask what exactly they want.
I humbly submit